afternoon, and welcome to a simplified approach to performance improvement. My name is Kaylin Henderson, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions in addition to a short survey at the end, and we ask everyone to participate as we value your interaction. Please allow me now to introduce today's speaker, Cindy Eisman. Cindy Eisman, MBA, is a project manager for HealthVisions Delmarva, a practice transformation network working through CMS, Transforming Clinical Practice Initiative. Cindy has over 30 years of experience in healthcare, starting in the area of health information management and expanding her skills in areas of expertise to performance improvement, operations management, healthcare financing, and practice transformation. Cindy has been a CEO, COO, and Regional Quality Operations Director with Health South, Kindred, and several community hospitals. Cindy is a native of Pittsburgh, a graduate of the University of Pittsburgh, and the Troy University in Alabama. Cindy, I would now like to welcome you to begin today's presentation.
Thank you, Kaylin. Welcome, everybody. I'm glad that you could join us today. I hope that this will be a informative session for you and something that you can use as we continue to work with your practices through the TCPI process. Before we start on our agenda, I just wanted to draw your attention to a few other upcoming events that we're going to be doing. We are co-sponsoring with NJAFP and the SIM in Delaware, a collaborative education session, a full day in November on the 15th at Dover Downs Hotel and Casino. The link is provided here if you have not registered and you would be interested in attending. This event is free to all members of the TCPI and Visions PTN, as well as those facilities participating in the SIM. Also, on that same day, but in the evening, there is a both on-site and webinar session on the macro final rule, or the QPP, Quality Payment Program. Dr. Barbara Connors will be in from CMS to give that presentation. It can be either attended in person at Kent General Hospital, or there's webinar access. There's also information on RSVPing and registering for that event on this slide. And the slides will be made available to you, to all attendees registered after this webinar. Finally, our next webinar in this series will focus on patient access, and that will be presented by Dr. Edward Sobel. He's the medical advisor to the HealthVisions Delmarva PTN, and we're planning that session for December 8th at noon using the same webinar program. So just to kind of let you guys know that that's upcoming out there. So what's our agenda for today? We want to touch on three areas. First of all, just the importance of a culture of quality within your organization and what that really means. We're going to look at the FOCUS-PDSA process, which is the quality improvement methodology we're using in the HealthVisions Delmarva PTN to help your practices move through this transformation journey. And then we'll have some time for questions and discussion. I do invite you to either chat with us or ask questions. I will say that we will hold verbal questions until the end of the question and answer session, but at any time you can type into the chat box. The first thing that I'd like you to put in the chat box, however, is if everyone out there attending could please just go into the chat box on the right-hand side of your screen and provide me the following information: your name, the organization that you're with, and the number of people who are joining you and listening to this call. We realize that some sites might have multiple people watching and listening to the webinar in one room. So if you take a few minutes to put your name, your company or hospital or practice, and then the number of attendees who are with you, that would be fantastic. The other thing is that you can type questions into the chat box at any time. We will answer those either during the Q&A session, or we will send them out afterwards in a document. We will answer all questions in the chat in that FAQ document, and it will be sent to all attendees. And finally, when we get to question and answers, you can use the raise hand icon to alert you, to alert us that you have a question or a comment, and that's best used again during that Q&A session. putting my name in. Okay. So while you guys are working on that, we also want to launch into our presentation, and we're going to start with polls. We have 2 polling questions that we're going to put up and ask you to answer, and it gives me an idea of where our listeners are in the process of transformation and in understanding performance improvement strategies. So, Kaylin, could you do that, please? So you see the polling question up there. If you could just check off the one that best describes you. Yes, I have received minimal training in performance improvement methodologies. I've received extensive training, or I have not received training in performance improvement methodologies. So we have some information coming in, and I think we'll give it a second more. 83% of the vote is in, or the polling is in. At this point, about more than 50%, 54, 55% have received minimal training. 12% have received extensive training, 35% no training. So that's good for us to know where we're starting at as we provide this education to our PTN members. Okay, Kayla, if you want to close that one and put up the next one. So this question is related. So for those of you who have some experience in performance improvement, how often do you actually use that in your clinical or business operations? Do you frequently use PI strategies to make change? Do you seldom use PI strategies to make change? Or do you never use PI strategies to make change within your practice? Okay, we're at about 61, 70%. Voting is much faster on this one. I'm coming in. So we have about 80% of respondents in, and 45% say they seldom use PI strategies to make change. 36% though frequently use PI strategies to make change, and that's excellent. That really does mean that we're taking the things that we've learned, the training that we've gotten, and we're applying it in our everyday practice. Really a small percentage, only 18%, never using PI strategies to make change. So thank you very much for the information. This does help a lot in helping me to know how to frame the conversation as we move forward. Okay, so let's launch it then. A culture of quality. What does it mean to have a culture of quality? Well, if we think about old management feelings about quality, there's some myths that kind of rise to the surface. You know, people felt that quality was expensive, that to have quality you would have to lower your productivity. That quality was intangible, that it couldn't be managed. It was not something that you could really impact. That poor quality meant poor workers. If there were problems with quality, it must have meant that our employees were not doing something right. Quality was the responsibility of quality professionals. There's someone who's our quality control person, and they're the one responsible. Quality isn't a major issue. It has little impact on patient engagement and outcomes. So these are some of the thought processes that were frequent in the healthcare community. But there's truth about quality that is much different than that. It's what we've learned over many years of using quality improvement principles within the healthcare setting. The truth about quality is that quality is cost effective, and it actually promotes productivity. Because if we're using good processes and creating good quality, we are doing it in a way that creates less rework and less problems. Quality can be managed, and it can be managed using simple tools and strategy. It doesn't have to be complicated. There doesn't have to be a lot of paperwork to it. It's really more of a mindset and an approach to how we approach problems and change. Poor quality means poor processes or poor planning, not poor employees. Almost in every instance, we can improve quality or correct problems through changing our process, through improving our planning, and by teaching our staff. So it's not that people are trying to do a bad job. We're not giving them the tools that they need to do it in the best way possible. Quality is the responsibility of all team members. It is not just the responsibility of your quality improvement professional. Everyone has a role in it, and team is really the way that we achieve great success within the healthcare setting. And then finally, quality has a major impact on patient engagement and outcomes. Patients don't know if we are clinically competent. They trust that we are clinically competent, right? They trust that when they go to the physician and he's an MD or a DO after his name, he knows what he's doing clinically. But what patients can judge is things that they're experts in. And patients are experts in whether you're nice to them, or whether they're waiting a long time, or whether they're getting the things that they're asking for. And so those are the kinds of things that impact your patient engagement and your patient outcomes. If we can engage our patients with high-quality services, with patient-centered and focused services, we can get better outcomes because we will get them more engaged in managing their own care. This is a quote from W. Edwards Deming. Dr. Deming was the grandfather, if you will, of quality improvement, kind of the way I look at it, in continuous quality improvement. And he wrote a book called Out of Crisis. His famous, one of his famous activities was that after World War II, he went to Japan and helped them to rebuild their business. And so a lot of the ideas he had here that weren't really followed immediately in the U.S., in the Western culture, were immediately taken up in the Japanese business culture, and this is why so many of those companies, Toyota and such, are at such a high level of performance. But he says that the job of management is not supervision, but it's leadership. The required transformation of Western style of management requires that managers be leaders. And that is a really important thing to remember as we start talking about the FOCUS-PDSA process. FOCUS-PDSA relies on teams. The team need leaders. And so your practice needs strong leadership in supporting these activities, in encouraging employees to participate in these activities, and they need strong leadership on each of the teams that we embark upon so that we keep people moving in the right direction. Our previous webinar provided by Dr. Russell Cole was on the topic of physician leadership in practice. That's a webinar that I think that we'll probably repeat at some point. It's an important message that we need to keep giving to all of our practices that we're working with. It is very important that the leaders of the practice are leaders and not just managing the day-to-day operation. So what are the characteristics of that successful leader? They understand the situation, they formulate and communicate a vision, they challenge traditional beliefs, they empower others and build coalitions, and exhibit authenticity and energy. So our leader has to be the one taking that first step, but it's really important that we look at the fact that they have to empower others and build coalitions. They have to involve others. We can't do this alone as individuals leading our practices. We have to work with the members of our practice to ensure their input and ensure things are being done in the best way possible. And what we want to do is follow the FOCUS-PDSA structure in doing that so that we make sure we're keeping them moving forward. Oh, good. Okay. Sorry. Okay, so I'll draw. Sorry about that, guys. So that's the successful leader. That's what a leader is. But now, what's the next part of it? It's that team that we want the leader to pull together. What are the characteristics of a successful team? They're educated in performance improvement methods. So we intend to accomplish that by just-in-time training. As we work with practices through their first performance improvement projects, if they have team members that haven't been educated on PI, we're going to provide that training as we do it just in time. We want to have our team members use data and information to make decisions. We need everyone in the practice to understand that data is important and that we can measure the things that we want to fix. Successful teams are empowered to make change. So the leader has really given them the power to honestly participate in the process and have a say in it. Successful teams are supported in their career development. They receive recognition of contributions and their efforts. And all of those things lead to a more positive attitude from our staff members, and that leads to improved performance and outcomes. So by implementing a structured performance improvement program, you can improve your employee engagement, achieve joy in the workplace, as we call it in our TCPI assessment, but most importantly, that's going to flow over to your patients. And when your employees have improved performance and a positive attitude, your patients will also have improved self-management and improved interactions with your practice. So out there in the literature, there are numerous methodologies for performance improvement. This little cloud map just gives names of some of the ones that are common. How do we know what to choose? Well, what we've embarked upon with HealthVisions is to use one of what we think are the simpler processes or simpler systems or models, and that's the FOCUS-PDSA model. In FOCUS-PDSA, we use the focus part of the process to drill down and clarify what is the problem that we're really working on, what are the root causes. And then we use the PDSA, Plan, Use, Study, Act cycle, to make a plan to correct it, do a small test of change, study the results of that change, and then act to either redesign or implement that change across the practice. It's a simple scientific model for approaching change within the practice. We're going to go through each of these letters in the FOCUS-PDSA cycle and talk about what we do at each stage. The way we're going to do that is we're going to walk through a case study. This is our case study. We have a practice, they're called Medical Incorporated, and they're beginning their process transformation. And when we did the assessment, and of course this is a fictitious practice, but when we did our fictitious assessment, it was discovered that they had a problem with missed appointments. There were simply too many missed appointments, no shows and cancels. The leadership of the practice felt that if this could be addressed, they could see more patients and would have better outcomes because the patients would be more engaged in their care if they're really returning for all their visits. The staff of the practice felt that their work would be more efficient if they were able to work with an established schedule and not have so many surprises in their day. Medical Incorporated is going to embark, therefore, on a rapid cycle improvement project using FOCUS-PDSA to address these missed appointments. So the first step in our journey is F for focus, at the beginning of focus. And F stands for find the process to improve. So whenever you're looking at a problem or you're trying to see where you want to take action or make change within your practice, you need to assess. You need to find out how are you doing in the things that are important to you. So in the TCPI initiative and through the PTN, we completed an assessment of the organization using that PAT 2.0 and came back and told you how you did on your assessment and created a 90-day plan with you. So we used that PAT 2.0 as well as any other information that was shared with us in our interview process to select an area that needs improvement. And then we collect some data to understand the scope of the problem. And it's really important at this point that you do take a step back and actually get some data to define your problem. It doesn't have to be huge. It doesn't have to go on forever. A small sample of 5 records, if you're looking for a documentation element, 1 week's worth of data, for example, in this case, if we might wanted to look at cancellations and no-shows if we didn't have data. But it doesn't have to be long. You can also use data that you've already collected, and it doesn't have to be an extra step. But the bottom line is, at this step, you do want to collect or find some kind of data that really demonstrates the scope of the problem. This is an example of how you might do that, or a piece of data that you might look at for our case study. They're going to look at cancellations and no-shows. So for this practice, let's say before we did our assessment, they had been tracking this. And what they could see was that in February, they had 85 either cancellations or no-shows. In March, it went up, and it peaked in April, well over 100, dropped a little bit at May, and then leveled back off, but still up in the 90s in June. So they had some data we could use. If we didn't have that data, we could have just kept track for a week or two of what the cancellation and no-show rate was, look at total number of appointments during that time, and really judge how big a problem it is. Sometimes your gut will tell you there's a problem, and then when you collect the data, you find out that's actually not really a problem. It's less than 1% of our visits. It might be something that we want to work on, but it might not be the most important thing to work on. So it's very important to collect data at the beginning in a simple way to validate your problem, and that's find a process to improve. So once we find our process and we have validated that it is a problem, we need to organize. O is for organize, to improve the process. And when we organize to improve the process, we have to create a team of appropriate staff and determine a goal statement for improvement. And I do want to stress here how important it is that we create a team to address the problem. A team could be 3 people if that's the only people that there are. A team could be 2 people if that's the only people that there are in the practice. But you need to get feedback and input from anyone that is touching that process. It's very tempting as a manager sometimes in a hugely busy practice to just say, okay, I see what the problem is, this is how we're going to fix it. And it's probably a great idea. I mean, as a manager, I've done this. You have a great idea and you think, I know how I'll solve this. But until you have really solicited the feedback of everybody who's touching the process, you aren't really going to come up with the best solution for the process. And so organizing and creating a charter is a tool we use to do that, is an important step to take once you have found the problem that you want to deal with. On your screen, you see an example of a charter. And so it's again, a simple document, doesn't take a lot of writing. We have no-shows and cancellations. This is the area for transformation. Our brief statement is we have too many no-shows and cancellations. This leads to inefficiency for the office staff, reduced appointment revenue, and poor patient outcomes when they don't follow through with their care. We want to reduce the number of no-shows and cancellations to improve efficiency and patient outcomes. That's our statement. Then we look at our data. The data we had was that during the first 5 months of 2016, we averaged 98 cancels or no-shows in each month, ranging from a low of 85 to a high of 112. And then we just say, see attached run chart. So the chart we looked at on the last slide reflects that data. Then we find our team members. This is a pretty large team. We'll say this is a pretty large practice. And so we have 1 physician member of our team. We have the practice manager. But see that we included a registration clerk, a medical assistant, a scheduler, and a nurse on our team. Because we need the input of all of those people to try to determine what are the root causes of cancellations and no-shows, and what are the things that we could do to try to improve that process. We're going to meet every other Tuesday in the Medical Incorporated Conference Room from noon until 1, so we'll do like a working lunch once every other week, and we'll do some activities in the week in between, homework if you will, to keep our project on pace. And we expect that we're going to complete our project by October 1st of 2016. It's important to put a end date on when you want to complete your project, and it's really important to try to do things that you can complete in a 90-day scope of a 90-day period of time. If you're looking at a project that seems so large that it would take far more than 90 days, you might want to step back and break that into smaller pieces and fix one piece at a time. Because if it takes forever to get to the end and see an improvement, you'll lose a little bit of that team momentum as you're moving forward. So it's really important that you select completion dates and that you think about all these areas when you form and charter a team. What is our statement of problem? What is our data? Who are the appropriate team members? And what is our target date? So now we move on to the C in FOCUS, which is to clarify our current knowledge of the process. And this is where we have to define the current process thoroughly and identify what you're currently doing. So on your screen, you have 2 tools that we might use at this stage. And the thing about performance improvement is you don't have to use every tool in the toolbox. We have a toolbox that we'll be using with you and sharing with you, but you don't have to use every single tool every single time. I will say that one of the tools that you will use in almost all of your projects is a process flow chart, and that's what you see on the right side of your screen. And in the process flow chart, what we do is we sit with the team in one of those 1-hour meetings, and we basically just ask the question, okay, what happened? How does this work? So this is our example for the scheduling and appointment process for Medical Incorporated, and we start with scheduling the appointment. And if you follow the arrows through this flow chart, you can see what happens. Each morning, registration runs a list of the day's appointments. Then you go down, well, does the patient call to cancel? If yes, then registration transfers it back to scheduling, and it goes back through the process again. If no, then they keep moving down, and the patient simply is a no-show. Okay, if there's simply a no-show, we just wait for the patient to call and reschedule. If the patient wasn't simply a no-show, then as the patients arrive, they sign in, they're registered and seen, they go to checkout, and do they need a follow-up schedule? If yes, then they check out, schedules the follow-up appointment, and we go back up and enter the top of the loop again. But we have a couple notes that we made here. At the top of that flow chart, at the very first diamond, where we had a decision to make, does the patient call to cancel? This process was to simply transfer that patient back to scheduling to reschedule. But they weren't asking them why they canceled, so they weren't really collecting any information about why that was happening. At the second decision box, I should be using my pointer. At the second decision box right here, does the patient simply no-show? This practice was simply waiting for the patient to reschedule. They just kind of let it go. And so that was their current process. It was important for everybody to be involved to explain what happens at each step of the way, and so that we can find where are these problem areas. For example, right here, if they just no-show, can't we call to find out why or to reschedule them? So this is the first step, is to understand what you're currently doing. Another part of this step could be to understand better why people are not showing or canceling. And so for this practice, had we really been doing this, we probably would have had to do, after we made this flow chart, was to say, okay, for the next 2 weeks, when people have to be sent to scheduling to reschedule, we're going to ask them why they canceled or no-showed. And for the next 2 weeks, when people don't show up, we're going to call them and find out why they didn't show or they canceled. So we're going to do those two things so we can collect data. And so let's say we did that. Let's say we were able to do that. And this is what we found. This is another tool that we might use, which is the Pareto chart. With the Pareto chart, you take the information that you receive and you figure out which is the most frequent occurrence or root cause. So in this case, we'll say that when we asked our patients why they had to reschedule or no-showed, most of them it was because they just forgot. They forgot that they had an appointment. They missed it. The second most prevalent one was a lack of transportation to get to the appointment. And then a few people were just too sick. They were sick in another way, and they didn't really need to go to the dermatologist that day because they were really dying of the flu. So that they couldn't come because they just weren't well enough. And then they had another smaller portion that just couldn't afford the copay. And so they knew they had an appointment, but they couldn't afford it right now, and so they skipped. We wouldn't focus on these two as our first solution. We would focus on these two areas for our first areas to address because they're accounting for the greater part of our problem. Forgot and transportation, if you add those together, account for more than 80% of the patients who cancel and no-show. So this is where we get the biggest bang for our buck, is to address these two areas. So it wasn't a complicated data analysis. There isn't multiple regression here. There's no complicated mathematical principles. It's simply keeping track of the reasons that things happen, putting them in order of prevalence, how frequently they occur, and working on the one that causes the most problem first. So that's what we do at the Clarify Current Knowledge step. I, of course, need to turn that back off. Right. So now brought to you in focus. What do we do here? We're understanding the sources of process variation. So we're understanding what are the true reasons. We are digging deeper and deeper at each step and to find what is truly the root cause. So a proximal cause is the immediate thing that we see. A root cause is what's really leading to it. So in this example, forgetting the appointment is the proximal cause. I mean, that's why they missed the appointment. But why did they forget the appointment is the question. And one of the exercises that we can use, and one of the simplest exercises we can use at this stage of the game, is something called the 5 whys analysis. And it's just exactly what it says it is. We're going to ask why 5 times. Sometimes that will keep digging deeper and deeper on the same issue, and sometimes it will identify multiple things that we need to address. But it ensures, by asking why 5 times, it ensures that we are addressing all the different issues that are going on. So, well, for a 5 why analysis, it's as simple as this. We have a problem. Why are people calling or canceling and no-showing for their appointments? And the 2 most prevalent ones we found from our Pareto chart in the last step was that they forgot their appointment or didn't have transportation. So if they forgot their appointment, why? Well, we don't give them appointment cards. So they didn't really have a tactile reminder of that to put on their calendar. Well, why? Well, we don't make reminder calls. So there are no reminder calls made. So maybe they did have that card, but it was lost in their purse and they didn't pay attention to it. And we didn't call them to remind them. Why? Well, we don't make reminder calls because there's not enough time for staff to make reminder calls. So there's an issue. Why else? No family support to assist to remind them. Maybe they have some cognitive issues and they can't remember. They need someone to help them and they don't have that family support to do that. Why else? Well, a patient could have cognitive difficulties and poor memory. Maybe you're in the wrong order, but it doesn't really matter. Bottom line is, there are a number of reasons that people could forget about appointments. And we probably need to look at how we can address each of those. Transportation. Well, why don't they have transportation? They didn't have time to arrange it. They didn't have time to arrange it because they forgot that the appointment was coming. So those could be tied together. Why else? They can't drive and they have to rely on their family, and their family works during the day, let's say. Why else might they not have transportation? Maybe they don't have family and they can't afford to pay for transportation. Why else? Maybe they live in an area without public transit. Or why else? Appointments are during the day, but family are only able to transport in the evening. So we go through a process of really just brainstorming in a structured way. What are the reasons that we're forgetting about appointments or having no transportation? That gives us kind of a menu of activities or focus areas to deal with that we will take into our next step, which is to select the specific process to improve. So we talked with the team and we had come up with those, we answered the 5 whys and we brainstormed what our issue areas were and what the possible root causes were. And after discussion, we settled on these 5 as being the ones that were the most important for us to deal with. We could provide appointment cards at checkout. That might be helpful. We could make reminder calls 2 days before the appointment. That could be helpful. We could notify a secondary medical contact of the appointment. We could provide patients with information on registering for low-cost transportation to try to deal with a little bit of that transportation issue, even though it was a smaller issue. And we could shift office hours for more evening appointments. What we do with these, so this is the 5 that we settled on. We want to try to do these things. Which one do we want to do first? Well, one way we can decide that is to use a tool called an impact map. And to use an impact map, what you really do is what you're seeing on the screen. You list what your planned actions, measures, and countermeasures could be. You give it a rating. How much impact do we think this would have on the problem? How impactful will doing this be? That's one thing. But the other thing we need to rate is how easy is it going to be to achieve? Will it be very easy to achieve? Will it be very difficult to achieve? And then once you rank each of them, we map it out over here. And this is how it turns out. Number 1 was to provide appointment cards at checkout. We said that that would have a moderate or a medium impact on the problem because people could still lose the cards. But it would be a moderate impact on the problem, but it would be really easy to do. We could get those cards made in about a week and start using them. So we take number 1, and on our impact map over here, we rate the impact on the vertical scale at 5, and then we rate the ease of doing it on the horizontal scale, and R1 ends up over here. So number 1, providing appointment cards at checkout would be very easy to do, but would have only a moderate impact on the problem. If we look at item 2, make reminder calls 2 days before the appointment, we think that would have a bigger impact, at least at an 8. But we think it's going to be a little harder to achieve. It's going to be moderately easy or moderately difficult to achieve because we either need to get an automated system or create time within someone's day to make those calls. So we take number 2, we go on the impact scale to 8, we come over on ease to 5, and it rates up here. So this one's going to have a high impact, and it's going to be only moderately easy to do. Number 3, notify the secondary medical contact, so another person. That would probably have a little less impact than notifying the person themselves, and it would probably be even more difficult to do because now we need to get other contact information, and it really doubles the phone calls we need to make. So what's our impact? It's up at 7 on the vertical scale. We move over the horizontal scale to the 3, which was ease of achieving, and that's where idea number 3 would sit. Providing patients with information on registering for low-cost transportation. That would have probably less of an impact on the problem, but it would be easy enough to hand them a piece of paper to explain that. So that one comes over here. It's easy to achieve, but it's not going to have much impact at all compared to the others on the problem. And then the same thing for shifting office hours. It's going to have a moderate impact on the problem, but it's probably going to be a little difficult to rearrange the whole schedule of everyone in the practice. So we take a look at this, and optimally, we would want some numbers to have fallen up here, right? We want the very easy things that are going to have a high impact. We didn't get any of those, and that's not uncommon. Most of the times, the things that are going to have a good impact aren't as easy to do, but that doesn't mean we don't do them. We would probably focus on 2 and 3, which is making reminder calls, because they're going to have the highest impact, and at least number 2 would be moderately easy to do. So the team decides that that's where they're going to focus on those areas. And that's an impact now. So we've worked through focus. We found our problem. We organized to fix it. We clarified what we know. We understood the root causes, and now we selected what process we want to improve. And now we're ready to actually do that. Keep forgetting to change my arrow back. All right. So we plan. P is for plan in the PDSA cycle. And in our plan, we state our objectives, we predict our results, and we create a detailed plan. This is an example of a detailed plan. It's a Gantt chart. And in a detailed plan, what we do is we spell out in here what are the things that we need to do, when are we going to do them, and who's going to be responsible for doing it. I don't have an example of stating objectives and predicting results on this slide, but that's very important too. We do need to remember what we're trying to do. If we had, on average, 98 no-shows and cancels a month, where do we want it to go down to? We actually have to predict. We want to cut that in half. So we want to reduce it by 20%. Is that a more realistic goal? So those are things that we need to do within our meeting minutes and in our plan, overall plan. But this detailed plan of who needs to do what is going to be vitally important for things to actually work the way they're supposed to. So you can see what the different steps are. We got a lot of detail. Create the report to schedule use for calls, create a script for them to use, train the schedulers in the new process, begin making calls. We're only going to do Dr. Smith's patients first. That's our small test of change. We're going to track his cancels and no-shows during the test. We're going to then analyze the results of how that went. Did it actually improve things? And if it did, we're going to implement it across the practice. And you see it's very stepwise. We're going in the first 2 weeks of August, we'll do this, the second and third week, the fourth week, and so we're planning out what happens. Then we're also going to try at the same time appointment reminder cards. We can actually implement that a lot earlier because it won't take us as much to get those printed. That's our plan. Now we do, and we study. I put these together because really in the do phase, we're doing it, and we're collecting the data that we're going to study. So when we do, we carry out the plan as a pilot. We want to measure performance under the pilot, and we want to document our problems that occurred. And then so after we're done piloting it, we go through that pilot process, maybe a couple of weeks, maybe a month, and then we study, complete an analysis of the results, and compare the outcomes to the prior state. And this is an example of doing that. So this is our run chart. Before this, Dr. Smith had per week around 10 cancellations or no-shows on his schedule. That's what his part of that 98 was. In week 1, he only had 8. In week 2 of the new process, he only had 5. And in week 3, we drop all the way down to 2. So we are able to show that by piloting it with Dr. Smith and following through on our plan, we did drop the prevalence of cancellations and no-shows by placing reminder calls and giving appointment cards. That tells us we're in a good place to implement this across the practice. So then we act. We either adopt or we would have abandoned it if it didn't work, but we adopt a new process based on the results, and we'll repeat the cycle until the desired results are achieved if it didn't work. Look, we made a new little Gantt chart up. So we found that it worked for Dr. Smith. What do we need to do to get all the doctors on board? Well, we have to train the remaining staff, begin making those calls, and then continue for a little while to analyze the results to make sure that you maintain the improvement that you saw. So we planned, we made a plan, we were very detailed in it and made assignments. We tried it with a small group of the patients, one doctor's patients. We studied the results that we got with that doctor, and then we acted to implement it across the practice. Basically, that's FOCUS-PDSA. Practice transformation is going to use this process. The PTN is going to use it with you to help you identify your opportunities for practice to meet the macro requirements for outcomes, utilization, meaningful use, and performance improvement. Your practice advisor is going to work with you to take you through this process and achieve your goals and teach these tools as we go. You, as the practice is built, are going to be the drivers of change in your practice and change that makes sense for your situation and your patient. It's not one size fits all. It's all about getting the input of all the team members. And then teamwork and open, positive communication are essential to a successful transformation process using PDSA. All right, so given that, I'm going to open it up to questions. Kaylin, if there's anybody out there.
You can either use your raise hand icon and I can unmute your line, or you can type your question into the questions like you did your name, and I can answer there. Okay, so we have a question from Barbara. This seems like a long process. Are there any issues where you wouldn't use this process?
Well, I think that you need to use the process, and there's a couple of key places that you don't want to skip, but it doesn't have to necessarily take that long. So let's take it in 2 buckets. Are there small changes that you can make in your practice? Like, for example, we tacked on almost to this example, let's give people reminder cards. Do we really need to convene a team to create a pretty standard reminder card and print it and give it to people? No. You can probably do that without the need to plan a lot or create a team to do it. However, in this example, making reminder calls, if you just said as a manager, well, what we really need to do is make reminder calls and here's how we're going to do it, but you didn't engage the schedulers in how their day works or the registration clerks in how their day works, or what your nurses or medical assistants know about what patients tell them when they're doing their intake about how hard or difficult or whatever it was to get to that appointment, you're not going to get the best solution. So I would say anything that requires you to change a process, change what multiple people are doing within your practice, I wouldn't skip this. I wouldn't skip steps. If it's something as simple as, geez, we should get reminder cards printed, we'll print reminder cards. And we'll hand those to people when we check them out. Sure, you could do that without a team. Now, that being said, does it need to take 90 days? No. You know, you could find the problem, clarify and make sure it really is the problem. Look, if your data is telling you that's the problem, then that's the problem. You could have one meeting of your scheduling group, for example, to deal with a small issue that's happening with scheduling. And then in that meeting, all in one step, understand what the current process is, map out what you want to do, and assign people responsibilities for those changes. So it can really be condensed into just a couple of meetings time, but going through the process of making sure you really are dealing with the right problem, that you have the right people weighing in on it, and that you have a solid plan for how you're going to change it, and then how you're going to measure whether that change worked. You can't skip those 4 steps. You need to do them in one way or the other.
Okay, we have Joseph raising his hand. Joseph, I'm going to unmute your line. You can go ahead and speak now. Joseph?
Dr. Parisi?
Okay. Oh, he typed it in. He said, any tips to get staff to buy into this process?
Yes. So, honestly, the best way to get buy-in is to put the skeptics on a team to work on a project that is important to them. So the way we approach this when we're talking with our practices about what we want to do first is, what is the thing that gives you heartburn? The thing that drives you the most crazy, the thing, if you had a magic wand or pixie dust, I could wave the wand and fix it for you. What is that thing? And that's the thing that you want to focus on first. The best way to get buy-in is to have a success. So what we say is we're always looking for that small win, that small, easy win. The thing that there's, you know, the problem that no one is going to say isn't a problem within your practice. So honestly, the best way to get buy-in is to pick an initial project that is meaningful to the staff and get them involved in the process so they see that it works. Once they see that it works, there will be no end to them coming up with ideas of things that need to be changed, that they would like to participate in changing. That's the biggest thing I can say. I think that the other thing is what that does when you create a team and you allow the registration clerks and the schedulers to participate on that team with the physicians, the nurses, and the medical assistants. It teaches everybody a little bit more about what the other people on that team do, and it shows your employees that they are important, that they're an important part of the process, and it gives them that feeling of belonging and really being a contributing member to the team. So just picking a project that, again, no one can argue with is an important project to do, is important, and then getting that win, working it through so that they can see that it's successful. Thank you, Dr. Parisi.
We have a couple questions on how you guys can gain access to this presentation. I just saved it in the handout. So you'll see a tab in your taskbar for handouts. You can download this slideshow from there. Also, a recording of this session will be emailed out to all the attendees and registrants once that file has been compressed. Okay. In the average family, this is from Dr. Parisi, he says, in the average family practice, what seems to be the #1 problem?
Well, the #1 thing, when we look at the assessment, the very first thing that most of our practices need to work on, although most of you have already, is identifying your vision. You know, what are you trying to be? Where do you want to go? And most importantly, what are the things that you're measuring or want to measure that will show that you've achieved the success that you're looking for? So mission, vision, and values is always first. But then after that, a lot of practices are not using performance improvement, so just implementing a system, and then the topics that they're dealing with. So if we look at what areas are we working on in our performance improvement team, patient engagement is really the top one, followed by patient flow, I'll call it. So it's how do patients actually move through the practice. So it kind of gets to wait time. You know, we arrive at the door, and then what all happens to them from the time they hit the door to the end. So those are the two, patient engagement and then patient flow are the two areas that most practices wants to work on and are starting to work on. I mean, I have to say that was, I was at the CMS conference this week, the Learning Alignment Network conference, and that was a huge focus for us there, was patient and family engagement. So I'm really happy to see that even without, you know, us pushing that, that has been something that practices have come up with as one of the first things they want to address.
Okay, we have another question. What is the simplest and easiest method we can use if this is the first time we will work on a project improvement?
Okay, what's the simplest and easiest method? Well, first of all, rely on your practice advisor to be your coach. So if you are a part of the TCPI project, you have a practice advisor through HealthVisions. If you are a BPA practice, you have support through the BPA organization, but you want to use your practice advisor and coaches. Sorry about that.
3, 4, 5, 6, 7, 8,
bear with us a minute.
9, 10. Testing. 1, 2, 3, 4, 5, 6, 7, 8, 9.
Very good. So, of course, we would test the overhead system during this webinar at our facility. I'm sorry about that. So, rely on your practice advisor to coach you through. Simplest process. Identify your problem. Identify your problems. Get the right people together. Ask the 5 whys, and create an action plan. So that's the simplest process to go through.
Let's see, we have about 7 more minutes of time. You can always raise your hand and I can unmute your line so you can talk to your question, or go ahead and continue entering your questions into the question bar.
I will tell you another, because we're working on patient satisfaction or engagement with a lot of practices, you know, we're all starting out at different places. Some practices who chose that actually have some kind of a satisfaction survey that they were doing, but they weren't really doing anything with it. They weren't aggregating the data or trying to interpret, you know, what to work on first or how to work on things. So with some practices, we're helping to interpret the data, create a way to display it, and then use it to identify really which area we want to focus on. We have one practice that's exactly what happened. They have a satisfaction survey, and we talked about it first, and wait times were the thing that just glaringly jumped off the page that we needed to deal with. So then our project really became about how do we reduce wait times in the waiting room for that practice. Other practices don't even have a survey. And so we are starting at helping them to develop a survey that will elicit information that is actionable, information that they can use to change and improve their practice. So it depends on where you're starting in the process as to what exactly you're going to do. But again, I would just recommend that you work with your practice advisor and as a coach to help you identify what to pull from the toolkit to use.
We have another question. Oh, I'm unable to download the handout. Can the presentation be emailed? Absolutely. The presentation can be emailed.
I know. So Taylor was reminding me that I'm sharing my screen. But I did want to show you this, and this is our toolkit. This is really just a list of all the different tools that we could use going through the FOCUS-PDSA process. And this is what your practice advisor uses to identify where we go next. Like, what are we going to do, first or next? And the thing that I wanted to point out with this is we can also send this out, and in fact, we can provide the whole toolkit. And it is available on the healthcare community site for those of you who have registered on the healthcare community site on our page. So the whole toolkit is out there, and we can provide it to you in a zip file also for your use. The important things that I wanted to point out here, though, was you don't need to do every single thing, right? You're going to pick and choose what makes sense. So to find your process to improve, we're not going to do the CMS assessment every single time. We're going to do that every 6 months. So that was sort of a one-time thing, and then we'll do a 6-month checkup. Maybe you'll collect data using a data check sheet. Maybe you already have the data and you don't need to do that, so then you would not use that, right? Maybe you would create a Pareto chart. That was the chart that told us what was the thing that happened the most frequently. Or maybe you won't. Maybe that's not what you need to do at that step. So this is more of a menu than a hard and fast, you must do each of these things. I will tell you that things that are absolutely important to do, a team charter is hugely important to do so that everybody knows what you're working on and that you've actually identified team members. And almost always, a flow chart is important to do. Anytime you are talking about changing a process, I think I said this before, that touches more than one person in your practice, you really should create a process flow chart to truly understand how it works. You can't change it if you don't understand how it actually works right now.
Okay, one last question before we run out of time. This might not apply to today's webinar, but why are these practices starting mission and vision names?
I'm sorry, I need to read that again.
This might not apply to today's webinar, but why are practices starting mission, vision, and names?
I'm starting with mission, vision, and names. Okay, great question. So it's very important. So this project, TCPI, Transforming Clinical Practices Initiative, it wasn't called the Getting Ready for MACRA Initiative. It was called Transforming Clinical Practice. So truly what we're trying to do is help practices to transform, to significantly change the way they are doing things so that they can be successful in any quality payment program, whether that's MACRA or whether Highmark or anyone else, United Healthcare, Aetna, Cigna, whoever it is, comes out with another program that's based on quality, that your practice is ready and able to participate in those programs. In order to do that, the practice has to know what it's doing and where it's going. And that's why we do a mission and vision and aim. So most practices have some kind of mission statement, and a mission statement is a statement of who we are. It's your current state of affairs. This is who we are. We are a provider of high-quality urology services in the greater Dover area. I'm making this up off the top of my head. That's who we are. Your vision statement is what you want to be. So if you want to be successful in quality payment programs, you need to be attractive to three, really probably more, but three significant audiences. Patients need to want to use your services. They need to like you. Payers need to want to use your services. They have to believe, so you need to be able to demonstrate to them that you are providing high quality care at a reasonable cost. And other providers need to like you, because other providers, specifically PCPs, and I'm speaking specialists now, but specifically PCPs, are going to be looking for specialists who can provide them with high quality service for their patients at a reasonable cost, because those PCPs end up being on the hook for, at least from a rating standpoint, all the costs that their patients accrue, not just the ones that happen in their practice. So having a vision that basically acknowledges that says, we want to be the choice of patients, the choice of physicians, and the choice of payers by being cost-effective, high quality, and engaged with our patients. So we need a vision. That's our vision. That's where we're going to go. The most important of the mission vision is the metrics, because metrics is how are you going to measure that you're doing that? How will you know when you are there? Will it be because your patient satisfaction scores are at a certain level? Will it be because your management of A1C is better than anybody else's? Will it be because you have a care management process in place that prevents people from falling through the cracks? So what are you going to measure? What's going to tell you when you're there? So we start with that. So that's kind of our overriding, that's our umbrella. No matter what activities then that we pick to work on as projects, they should impact our vision. They should impact our vision and our metrics. So we shouldn't be working on things that don't support what your vision of your practice is. So if your vision, and one last statement on this, if the vision for your practice is to be the most cost-effective option in your community, you don't want to work on a project that's going to increase cost. That's not going to be helpful. So that's why we do the mission, vision, and metrics first, and I hope that answered the question.
All right, well, we have exceeded our time. Thank you, everyone, for joining us today. Thank you, Cindy, for this presentation. A recording of this presentation will be sent out, as well as I will email all attendees the PowerPoint that was presented.
Thank you, everyone.